here. Okay, so which of the following is the most likely cause of this patient's presentation? So if you are able to see here, the options are aspergillus, botulella. So it is saying there. So see, which of the following is the most likely cause of this patient's presentation? So if you see here, you are able to see lots of blue cells. So these are what? These are something lymphocytes, and lymphocytes are seen in the infection of the virus, and it's a typical presentation of the Epstein-Barr virus. So this is post-transplantation lymphoproliferative disorder. So if you see the etiology, so look at here. Etiology says that immunosuppression following solid organ and hematopoietic stem cells transplantation suppress cytotoxic T cell immunosurveillance Epstein-Barr virus proteins derive unchecked B cell growth or expansion. So carefully see here, guys. We have to complete a lot of portion here. So if you see the etiology, so there is immunosuppression following solid organ hematopoietic stem cell transplantation. So immunosuppression is after solid organ transplantation. After organ transplantation, you have to give the immunosuppression to the patient. So what it does, it suppresses the cytotoxic T cells. T cells. So this is immunosurveillance. Epstein-Barr virus encoded protein derived unchecked B cell growth or expansion is there. So talking about manifestations. So if you see the manifestations, mononucleosis like symptoms are the example: fever, night sweats and hepatomegaly and lymphadenopathy. Extranodal mass in approximately 50%, and biopsy findings polyclonal or monoclonal B cell proliferation you can see. So if you see here, you can see the patient underwent organ transplantation and is on high dose of immunosuppressive medication due to acute organ graft rejection. So he subsequently developed mononucleosis like symptoms: fever, night sweats, lymphadenopathy, hepatomegaly, leukopenia, and biopsy showing large atypical B cell completely effacing the lymph node architecture. So this constellation of finding likely indicates a post-transplantation lymphoproliferative disorder that is called PTLD. Talking about this, so PTLD is a plasmacytic or lymphoid proliferation that occurs in weeks or months following solid organ hematopoietic stem cell transplantation. caused by proliferation of Epstein-Barr virus in donor or host cell, reduced cytotoxic T cell surveillance, high dose immunosuppressive therapy. Okay, talking about the Epstein-Barr virus, its replication promotes B cell proliferation due to expression of viral membrane proteins, lateral membrane protein that mimic B cell antigen stimulation signals. It also promotes B cell survival due to expression of viral nuclear transcription factors EBNA2-LP that activate a host survival gene. These virus mediated changes generate immortalized plasmacytic or of lymphoid cells that proliferate widely in reticuloendothelial system into lymphadenopathy, hepatomegaly, and B symptoms. So, if you see Epstein-Barr virus replication promotes B cell proliferation due to expression of viral membrane proteins that mimic B cell antigen stimulation signals. It also produces B cell survival due to expression of EBNA2 that activates host survival gene. The virus mixture changes general immortalized plasmacytic or lymphoid that proliferate widely in the reticuloendothelial cell, that is macrophages, leading to lymphadenopathy, hepatosplenomegaly, and B cell symptoms. B symptoms. So this is the thing. So 1 minute, guys. So this is B cell proliferation due to expression of latent membrane proteins. So B replication EBV is Epstein-Barr virus replication. It promotes B cell proliferation due to expression of viral membrane proteins. So Epstein-Barr virus, it promotes B cell proliferation. It is similar to mononucleosis. So B cell antigen stimulation is mimicked by the Epstein-Barr virus. So it also permits B cell survival, and it due to expression of viral nuclear transcription factors EBNA2, these virus-mediated changes generate immortalized plasmacytic or lymphoid cells. Immortalized means the B cell survival has increased that proliferate widely in the reticular endothelial cells. So if the B cells are proliferating a lot, you will get lymphadenopathy, hepatosplenomegaly, and B symptoms. Example: fever and night sweats. Choice A: invasive aspergillosis is common in those with neutropenia, profound neutropenia following transplantation. So, if the patient having a transplantation, after that he is having neutropenia, that is invasive aspergillosis. However, it primarily affects the lungs, not lymph nodes, and is marked by fungi with septa, hyaline, hyphae, and acute angle branching, tissue necrosis, hemorrhage, and invasive invasion of tissue planes are prominent. Invasive asphyxia is common in those with profound neutropenia following transplantation. However, it primarily affects the lung but not lymph nodes. So, for aspergillus, you should remember asper is acute angle branching. Aspergillus is acute angle branching is there, and it primarily affect the lungs, not the lymph nodes. Lymph nodes, Epstein-Barr virus mononucleosis, marked by fungi, septate hyaline hyphae. Septate hyaline hyphae is there. Bartonella henselae causes cat scratch disease. Cat scratch disease is caused by Bartonella henselae. Henselae is causing cat scratch disease, which is associated with regional lymphadenopathy. Regional lymphadenopathy is there. Histopathology demonstrates necrotizing granulomatous adenitis with a multinucleated giant cells, stellate granulomas, and microabscess. Specialized stains can reveal the bacterium. So it is caused by Bartonella henselae and it causes cat scratch disease. Here you will find specialized regional lymphadenopathy, and in histopathology you will see necrotizing glomerular nephritis with multinucleated giant cell, stellate granulomas and microabscess. You will see necrotizing granulomatous adenitis and multinucleated giant cells and stellate granulomas. Patients with severe immunocompromisation from AIDS or immunosuppressive medications can develop Cryptococcus neoformans. Cryptococcus neoforman infection is usually present in meningoencephalitis, and headache and vomiting and confusion and pneumonitis is there. Disseminated infection is less common and primarily affect the skin and skeletal system. Histopathology will show budding encapsulated yeast. So immunocompromised patient, they have Cryptococcus neoformans, and here it usually presents with meningoencephalitis, and disseminated less common, primarily affect the skin and skeletal muscles. So it commonly affect the skin. So skin is affected and the skeletal system is affected. So histopathology will show budding and encapsulated yeast. Budding and encapsulated yeast is seen in Cryptococcus neoformans, common in AIDS or immunosuppressive patients. Option is chronic or reactivated parvovirus infection can occur in severely immunosuppressed individuals. Severely immunosuppressed, then parvovirus is there. Although this frequently causes fever, fatigue, and sometimes leukopenia, most cases are marked by severe anemia due to red cell aplasia. In addition, generalized lymphadenopathy will be atypical. Educational objective post-transplantation lymphoproliferative disorder occur in patients who have undergone solid organ or stem cell transplantation, high dose of immunocompressive suppressive medications caused by reactivation of Epstein-Barr virus, which generates viral protein that stimulate B cell proliferation and survival. So, mononucleosis-like symptoms can be seen in post-transplant proliferative disorder. So, did you understand? Here we have covered mononucleosis. We have covered that Epstein-Barr virus. It stimulates B cell proliferation and patient and survival. B cell proliferation and survival is in Epstein-Barr virus. Epstein-Barr virus, and it is seen in the patients who are having solid organ transplantation or stem cell transplantation. They are high dose. They are on high dose of immunosuppressive medications. And these Cryptococcus neoformans seen in AIDS patient or immunosuppressive patients, and this Cryptococcus neoformans, meningoencephalitis, headache is there, vomiting, confusion, pneumonitis. Generalized lymphadenopathy would be atypical. So here you can see here sheets of large atypical lymphoma cells. So lymphoma cells you can see non-Hodgkin's lymphoma. This is invasive aspergillosis. Lung-like symptoms are more when compared to other symptoms. So here you can see fungi with acute branching. Acute branching. Acute branching you can see. Acute branching is there. Not if obtuse branching, then some other. Acute branching is there. Next question. 47-year-old. Okay. So, 47-year-old man, woman, she is gravida 2, para 2, comes to the office after noticing a pea-sized lump. So we have seen this question previously. So there is a pea-sized lump in her right breast while she was taking a shower. She observed, and she has a history of taking cigarettes when she since she was 20s. In her 20s, she takes 3 pack for 3 pack years of cigarette use. So she underwent infertility treatment and now she is Gavida 2P2, and she don't have any family history. And so there's a puckered skin and highly suspicious of malignancy, and needle biopsy revealed infiltrating ductal carcinoma. A right mastectomy and axillary lymph node dissection are scheduled. Of which of the following markers is most likely to be associated with aggressive disease in this patient? So aggressive disease is related with HER2 expression. HER2 expression is associated with aggressive disease. Let me tell you how. So there is a human epidermal growth factor receptor 2. This HER2 or ERB2 is a member of epidermal growth factor receptor family, and it is expressed in 20 to 30% of breast cancers. HER2 is transmembrane glycoprotein with tyrosine kinase activity. It is a transmembrane glycoprotein with tyrosine kinase activity that acts to increase cell proliferation. It's a pro. So So in breast cancer, HER2 overexpression positivity is associated with poorly differentiated, rapidly growing tumors. So HER2 overexpression associated with poorly differentiated means it's aggressive, and it is rapidly growing tumors. HER2 status is used to predict therapeutic response of anti-HER2 monoclonal antibodies, that is trastuzumab. Trastuzumab. So, if options A, if you see BCL2 protein, so overexpression of anti-apoptotic. It is anti-apoptotic means it will not let the cell die, but it will help in proliferation. So, it's classically observed in follicular lymphomas or also seen in other malignancies, including breast cancer. Unlike in lymphomas, increased expression of BCL2 cancers with a favorable prognosis. Prognosis is good in BCL2. If you see breast cancers, express high levels of estrogen or progesterone receptors are typically associated with improved outcomes. Pressure of these receptors act as a stimulus for tumor growth. Therefore, anti-estrogen therapy, aromatase and tamoxifen, if you give in these patients for receptors, estrogen and progesterone receptors, then it will treat hormone receptor positive breast cancer. But overexpression of a mutated P53 is found in many human cancers. Breast cancers, degree of protein expression does not correlate well with clinical outcomes. So rather, the effects on prognosis are more dependent on specific mutation, gain of function. So if you see estrogen progesterone receptor positive indicates expected sensitive tamoxifen and aromatase inhibitor treatment. HER2 overexpression in breast suggests a more aggressive tumor that typically responds to therapy with anti-HER2 monoclonal antibodies. This trastuzumab. Okay, fine. So here, if you see this expression of HER2 new expression in breast cancer, just a more aggressive tumor, it will respond to monoclonal antibody, that is transumab. Transumab. Reference American Society of Clinical Oncology, tumor markers in breast. Now let's talk about a 26-year-old man. He comes to office due to myalgia. Myalgia is pain, muscle pain, and nasal congestion. Nasal congestion means the secretions are not coming out; they are stagnant there. And cough. Temperature is this much. He's having fever. Pyric Okay, pyrexia is there. Examination shows nasal and pharyngeal hyperemia. There's something with the pharynx, okay? Hyperemia means it's red, excessive redness and swelling. Rapid influenza antigen of nasopharyngeal testing is positive. If you see within the infected cell, the patient's respiratory tract When viral proteins are degraded attached to major histocompatibility complex MHC1 molecules which are expressed on the cell surface for presentation cytotoxic CD plus 8 plus lymphocytes. Which of the following enzyme is most essential to initiate this response? So it is saying that the patient is for positive for rapid influenza antigen. It's positive for influenza. So within the infected cells of the patient respiratory tract, viral proteins are degraded and attached to major histocompatibility complex 1, which are then expressed on the cell surface for presentation to cytotoxic CD8 plus lymphocytes. Most essential to initiate the immune response. Enzyme is ubiquitin ligase. This is the correct answer. Let's check. Yes, so the ubiquitin ligase E is the correct option. So what is happening is this is the target protein which has to be degraded. Suppose this is the viral. What happened? Then switched off. Okay. So this is the target protein which has to be degraded, and there should be some ubiquitin. So the ubiquitin and the target protein will bind, and this is a proteasome which will be ultimately lysing it. And now if you see the proteins are degraded, hydrolyzed oligopeptides, and you can cleave from target protein and recycle. So for the binding you need ubiquitin ligase. So the cellular immune response to viral pathogen, example influenza, requires the presentation of viral antigens, example CD8 plus lymphocytes. Ubiquitin pathway is essential. So is essential. So if you see here, the peptide fragments. So the viral antigen should be presented to the immune cell. That is CD8. CD8, because virus will be taken care over by CD8 positive lymphocytes. The ubiquitin proteasome pathway, that is UPP, is essential to this because its role in breaking down native and foreign intracellular proteins. So ubiquitin ligase initiates the UPP by recognizing specific protein substance and analyzing and catalyzing the attachment of ubiquitin. So ubiquitin ligase, it recognizes the specific protein which has to be degraded, and it catalyzes the binding of the ubiquitin. Then the proteins tagged with ubiquitin broken down by a proteasome to peptide fragments which can be recycled into amino acids. So the peptide fragments produced during this process can be coupled. So they can be recycled if it is native one, and if it is viral one, it is going to be um, coupled with the major histocompatibility complex, that is MSC class 1, and in the endoplasmic reticulum and presented on the cell surface. Cytotoxic CD8 plus recognize non-native viral proteins on infected cells and trigger apoptosis of the cell by activating the cascade through the release of perforin and granzyme. Okay. So if you see choice aids, it has acid phosphatase. So acid phosphatase, it is seen in the lysosome. Lysosome, it is seen in the lysosome and of most cells and hydrolyzes organic phosphates, but it is not involved in antigen presentation. It hydrolyzes the phosphates. Acid phosphatase is hydrolyzes the phosphates, organic phosphates in the cell of the in the cell. And the now talking about guanylate cyclase, it is the G protein involved in G protein signaling cascade. It plays a crucial role in the activation and regulation of diverse physiological processes like relaxation of the smooth muscle, retinal phototransduction. So G protein signaling cascade requires guanylate cyclase. Malaperoxidase is a key component of the respiratory burst of neutrophils released into the phagocytic vacuole and extracellular space, part of immune response of bacteria and other pathogens. If bacteria is there, other pathogens are there, then myeloperoxidase of the respiratory burst of neutrophils and released into phagocytic vacuole. Slur space as part. So phagocytic vacuole is there, na? There the myeloperoxidase is there, and it causes the lysis of the bacteria. Neutrophils engulf it. Okay, essential step in the activation of cellular immune response to a virus is the breakdown of intracellular viral protein by ubiquitin proteasome pathway. This pathway initiated by ubiquitin ligases and it recognizes specific protein substrate and attaches a ubiquitin tag. Target will degrade by proteasome into peptide fragments which coupled to major compatible class 1 presented on the cell surface for surveillance to the by cytotoxic CD8 plus. So if you see, this is a cell. Okay, this is the endoplasmic reticulum you are seeing. This is endoplasmic reticulum. What you are seeing? This is endoplasmic reticulum, and this is having MSC class 1. Okay, MSC class 1. So these is what intracellular pathogen. This is proteasome binding and peptide fragments are formed. These peptide fragments they enter into the endoplasmic reticulum to tap proteins, and these viral proteins, whatever the peptide fragments are there, these are going to be binding with the MSC class 1, and these are going to be expressed on the cell surface. And now CD8 plus T cells, they will see, oh, this cell is having the viral proteins, and now they will uh, cause the lysis of the cell, apoptosis of the cell by the release of the enzymes like granzyme and perforins, and trigger the apoptosis of the cell. So this is the cell. So some virus came into the cell. This virus is handled by proteasome and peptide fragments are formed. This enter into the endoplasmic where MSC class 1 will bind with it, and it will come to the surface and show that this cell is having some viral protein. So the CD8 plus T cells, it will cause the lysis apoptosis of the cell by releasing perforins and granzymes. I think you understood. Now let's talk about another question. Okay. A 24-year-old man is evaluated for recurrent episodes of abdominal pain and bloody diarrhea, also low grade fever and fatigue. Examination reveals left lower quadrant tenderness. Left lower quadrant. So, see, this is your abdomen, this is your umbilicus. Right, suppose this is the right side and this is the left side. I think I should write up. This is the abdomen, this is your umbilicus, this is your left side, this is your right side. Right side you have the liver, and left side you have the stomach, and then you have the here intestines and all are there. So right upper quadrant, if you see, this is the liver. Left upper quadrant, left lower quadrant, then it will be some rectum or colon. Okay, CT scan of the abdomen, thickening of the distal colon and rectum. So it's saying distal colon and rectum is there. During one of the laboratory, the patient anticoagulated blood is placed in an upright thin glass tube and left undisturbed. So this is the thin glass tube. So anticoagulated blood is kept because this is coated with EDTA. Okay, so the blood is kept in it and left undisturbed. His blood cells form a stack and settle to the bottom and at the fast rate of 50 mm per hour. Serum levels of which of the following substance is most closely with this observed finding? So this is a good question. So physical examination reveals lower quadrant tenderness. CT scan of the abdomen shows thickening of distal colon and rectum. So the distal colon rectum, this is related with the inflammation. Okay, inflammation, inflammation. So, and the RBCs are also getting stacked, at a fast rate. Okay, so this is can be interleukin 6 because there's some inflammation. Let's see. Yes, interleukin 6. So I'll tell you how it's possible. So this patient who has recurrent abdominal pain and light diarrhea, and the series evidence of bowel thickening is there in the distal colon and rectum. This is a case of some inflammation, that is ulcerative colitis. Ulcerative colitis. The patient is having ulcerative colitis. Ulcerative colitis. The chronic inflammatory conditions are characterized by persistent stimulation of neutrophils and macrophages linked to long-term elevation of circulating pro-inflammatory cytokines. Okay, cytokines such as interleukin 1 and 6 and tumor necrosis factor alpha and interferon gamma. Remember that interleukin 1, 6 and TNF alpha and interferon gamma, these are there. The liver responds to these circulatory cytokines by generating acute phase reactants. Acute phase reactants. So acute phase acute phase reactants. So the liver responds to the cytokines L1 6, interleukin 1 6, TNF alpha, interferon gamma by producing acute phase reactants and play some role in innate immunity. The testing of acute phase reactant can help diagnosis and track as something associated with inflammation. So, including infections, autoimmune disease, malignancy. The test described in this is ESR, which begins by placing whole blood in a narrow vertical tube. The erythrocytes settle at the bottom of the tube over time due to gravity as the density is greater than plasma. So ESR is a measure of the length of plasma on top of the erythrocyte sediment layer at 1 hour. The presence of acute phase reactants, particularly fibrin globulins, causes erythrocytes to overcome the zeta potential and form a stack, that is Rolex formation, because the RBC is having some negative charge on it. So they will overcome from it by fibrinogen and globulins, to overcome the fibrinogen and globulins, which settles to the bottom of the tube more quickly and increase the ESR. So if ESR increased, it means the body is having fighting with some inflammation. If the body is fighting with inflammation, the ESR will be increased. It means the liver has released some acute phase reactants as the inflammatory response. Acute phase reactants. These acute phase reactants, fibrinogen and globulin, they cause the Rolex formation by causing erythrocytes to overcome zeta potential. Okay, so this is the case. Now let's talk about another aspect, options about another options. So bradykinin is a component of the kinin system. So bradykinin kinin system, shortly it causes vasodilation. Vasodilation increases vascular permeability and stimulates endothelial smooth muscle dilation and mediates pain. So if you see bradykinin is belonging to the kinin system. It is short-lived peptide, and it causes what? It causes vasodilation, increased vascular permeability. It stimulates endothelial smooth muscle dilation and mediates pain. Erythropoietin is a growth factor for erythrocyte precursors and bone marrow produced by peritubular cells of the kidney response to hypoxia. Leukotriene B4 is a metabolite of arachidonic acid. Leukotriene B4 is a metabolite of arachidonic acid. So leukotriene B4, it is a metabolite of arachidonic acid, and its main function is to stimulate neutrophils migration to the site of inflammation. Not platelet activating for release by endothelium. Platelets and immune cells are involved in leukocyte function. Example: endothelium attachment, phagocytosis, degranulation, stimulation and changes of vascular tone and permeability. Now let's talk about the thromboxane A2 is one of the products of cyclooxygenase pathway and is synthesized by platelets and cause platelet activation and aggregation. It does not cause heterocyte rollers formation. So A2 it causes platelet aggregation and activation, and it belongs to it is one of the product of cyclooxygenase pathway. So, if you see chronic inflammation is associated with increasing circulatory pro-inflammatory cytokines 1,6 interleukin 1,6 human aggressive factor alpha and interferon gamma, which stimulate the liver to release acute phase reactant that is C-reactive protein fibrinogen. The presence of acute phase reactant increases the sedimentation rate, a non-specific marker of inflammation. So let's talk about another question. A 36-year-old woman is there and she came to the office after she noticed some lump under her arm while she was getting dressed. She says she feels fine and has no other symptoms. Her medical history is significant for hypothyroidism. She has hypothyroidism. Family history is negative. Examination her body mass index 24 kg per meter square. Breast exam shows non-tender left axillary lymphadenopathy. The patient sent for ultrasound biopsy, guided biopsy of the specimen shows clumps of cells have positive immunohistological histochemical staining for cytokeratin. Cytokeratin is related with keratin. Keratin is found in skin and skin is related with epithelium. Let's see the question. 185 kD glycoprotein that spans the cell membrane as tyrosine kinase activity in the intercellular domain. Which of the following is the so answer is right. It is epithelium. Cytokeratin proteins that help form the keratin containing intermediate filaments that make up cytoskeleton of almost all epithelial cells. Highly abundant in exposed stratified squamous epithelium, epidermis, and oral mucosa, and less abundant but still present in simple epithelium such as that found in liver, gut, and pancreas. As a cytokeratin is commonly used immunohistological marker, histochemical marker for epithelial derived tumors. Cytokeratin is the epithelial derived tumor marker. Such as breast cancer, keratin is also a major protein component of hair and nails. Is composed of large amounts of alanine and glycine that helps a because of the small structure able to coil tightly large number of hydrogen bonds. Alanine and glycine. Keratin contains a significant amount of sulfur containing amino acid cysteine and formation of disulfide bonds between cysteine residues gives additional rigidity and toughness to the protein. Formation of disulfide bonds between cysteine residues gives additional rigidity and toughness to the protein. Additional rigidity and toughness to the protein because there is another sulfur containing amino acid. This sulfur containing amino acid is cysteine. It's composed of large amounts of alanine glycine because of this. Okay, they are forming hydrogen bonds and disulfide bonds because of cysteine presence, and it gives additional rigidity to the keratin. So keratin is very strong. It is not water soluble. So in our chemistry, during our intermediates, we had a question called is keratin water soluble or not water soluble? So obviously it is not water soluble because if it is water soluble, whenever we take bath, then keratin might flow like anything. So it's not water soluble because it's having a strong bonds because it has cysteine, alanine, glycine. Alanine, glycine, so hydrogen bonds are there. Cysteine, sulfur bonds are there. that is disulfide bonds are there. Talking about the options, CD20 is a marker is to identify B lymphocytes. So B lymphocytes, A lymphocytes, and B lymphocytes are, sorry, B and T lymphocytes are there. The B is 220. So CD20 is a marker, and CD3 is for T3 is the same. So CD3 is used for T lymphocytes. White vimentin is an intermediate filament present in mesenchymal tissue and can be used to detect sarcomas. For sarcomas, we have to detect mesenchymal tissue. Mesenchymal tissue is having intermediate filament as vimentin. Okay, myeloperoxidase enzyme that can be used as a marker for myeloid cells, such as those in acute myeloid leukemia. So, if someone is having AML, 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 then as a marker for myeloid cells, such as those in acute myeloid leukemia, and chromogranin A and synaptophysin are markers used for neuroendocrine tumors. Chromogranin A and synaptophysin. Synaptophysin and chromogranin A. Cytokeratin is commonly used histochemical immunohistochemical marker of epithelial cell carcinoma because it has keratin. Even epithelial cells, squamous epithelial cells have keratin in small amounts. The cells identified by the special immunohistochemical are shown to express this we have done, right? No, we have not done this question. This is different question. Yes. Sorry. Talking about special immunohistochemical stain used to overexpress, shown to express 25 kD glycoprotein that spans the cell membrane and has resin kinase activity. Intracellular domain. Which of the following is most likely function of this protein? So this is a function. Tyrosine kinase activity is there means it is having a extra cell proliferation activity. So HER2 oncogene codes for human epidermal growth factor receptor with tyrosine kinase activity in the intracellular domain. It is known to play a role in the activation of transduction pathway to control epithelial growth and differentiation. As in overexpress HER2 demonstration. So transumab is a monoclonal antibody to treat the who test for positive for overexpression of HER2. Estrogen progesterone receptor we give and the drugs like acromatase and all, and aromatase, aromatase and so intracellular binding mediated by cell surface resistance, addition molecules, lectins, and numerous others. Sixty-four-year-old male, diarrhea, abdominal pain, nausea, vomiting, anorexia. 3 weeks ago, after starting radiation therapy for prostate cancer. Abdominal tenderness, sigmoidoscopy reveals hyperemia, edema, erosion, sedation of the intestinal mucosa. Stool and serum chemistries are normal. Patient entries is suspected. So that is the most common primary mechanism responsible for this patient's understand changes. Let's discuss in next class.